So we're going to be talking about neuro-oncology. I know this is a broad group, so I kind of made it hopefully understandable and useful to everyone here. And I'm going to start with the last slide. Everyone is involved in the care of our patients. Our patients is very dependent on every one of us doing our part to the best that we can do. Getting patients in, getting patients seen, getting patients on chemo, getting the chemo in, getting the follow-up, and all of that is essential to how well our patients do, how long they survive, and how many complications they have from the toxic drugs and things that I'm prescribing to them as well. We're going to talk about brain cancer, the biology of brain cancer, starting with the basics as well, the barriers to effective treatment in neuro-oncology specifically, and then we're going to go into some of the details about what we're actually treating. And we're going to really highlight glioblastoma, which is the most common malignancy of the brain in adults, and how that is, what that is, how that affects our patients, and what are the treatments that we have for that. And then we're going to talk a little bit about clinical trials. The brain is really made up of a couple of different cells. There are neurons, which everyone thinks is the main component of the brain, but actually the majority of the brain is made up of glial cells. These are the cells that surround the brain, provide support and structure to the brain, are probably critically involved in neuronal messaging, and make up about 80% of the brain matter. So most of the brain is not neurons, most of the brain is glial cells. And so naturally, most of the cancers that start in the brain are of glial origin. And those can be astrocytes or oligodendrocytes. The other cells that make up the brain are blood cells. And so there's specialized blood cells that are involved in brain transmission as well. And immune cells. The initial thought was the brain has its own immune structure, that most of the cells in the body don't cross and get into the brain because of the blood-brain barrier. So it has its own microglia and immune structure that is independent of the body. And so we're trying to shift that paradigm a little bit. And so you can see that blue neuronal cell is surrounded by about 10 glial cells in red, yellow, and green, and they provide the structure, the mechanism by which transmission occurs, as well as the immune-mediated component of things. And so what happens is occasionally these cells start to divide. Normal cell division is through this traditional mechanism. Neuronal cells almost never go through this. So neurons, essentially when you're born, you have all the neurons, and then you prune away. Very rarely do neuronal cells regenerate or divide in adulthood. Glial cells do it, but far less than most of the body. So this cell replication cycle that we all know from, I guess, high school, still present, but not very active in normal neuronal tissue. However, cancer cells go through this at much more rapid rate. And so what happens is in DNA replication, typically there's mutations that occur in the DNA that lead to them becoming constitutionally active, meaning they can divide and grow without regulation from the body. Normally, if there's a mismatch in DNA, the body goes through a mechanism to get rid of that. But cancer cells develop these aberrant mechanisms, and so don't go through that apoptotic process. So the body, very smartly, if there's an error in a cell, instead of saying, let's try and fix this error, most of the time it just says, let's get rid of it. Let's go through apoptosis, break down the cell, and get rid of it. Occasionally, cells become so aberrant that they break down by themselves, and that's called necrosis. So when the cell breaks down without a controlled mechanism, it's called necrosis. When the body gets rid of it, it's called apoptosis. Apoptosis is the anti-cancer mechanism of the body. So what goes wrong? And what is cancer in the brain? Essentially, it's broken down to unregulated cell growth. So normal cells can go through hyperplasia, where they become too many cells. They can go to dysplasia, where those cells become abnormal. And then that transforms into cancer. So cancer is hyperplasia plus dysplasia, meaning too many cells, too many irregular cells, and those cells are now spreading to areas that they shouldn't be going into. The main thing is, in order to really be a cancerous tissue, it has to avoid apoptosis, meaning it has to have a mechanism by which the body doesn't recognize this as foreign, and doesn't get rid of it, doesn't get rid of the problem. And so all cancer has some mechanism that avoids apoptosis. So that's how we're going to fight it. So we want the body to recognize it, we want the cells to get rid of it, or we want to cause it to go through necrosis. That's how all cancer works. But there are specific things that make it difficult in neuro-oncology. There's specific ways that what we're doing systemically doesn't always work with the brain. And so there's access issues. Obviously, the brain is in a restricted area. You can't get to it very easily. For a craniotomy, it's an elaborate ordeal. Obviously, the brain is very important. I'm not just saying that because I'm a neuro-oncologist, but it controls everything else from motor, language, vision. So you can't just take it out, right? You can't remove most of the brain. There's also this blood-brain barrier. So things that are getting systemically are prevented from getting into the brain. It's a defense mechanism for the brain, but it also keeps most chemotherapies from getting in. And we know that brain cancer has developed more than one way to avoid apoptosis. So it has escape mechanisms. You shut down one pathway, it's going to go through a different pathway. So it has these built-in ways to avoid things that we're doing. And a lot of that is genetics. And so we're trying to understand those genetics of cancer. And then it has immune protection. I mentioned that it has its kind of its own immune cells. So immunotherapy is a new area of cancer research, but has some issues with the brain because we think that the brain may have a different mechanism. But more importantly, going back to the basics of cancer, it does prevent the immune system from recognizing these cells as foreign. If we can get the body to recognize these cells as foreign, then it can use that mechanism. If we can't, nothing works in cancer therapy. So let's talk about access. So the brain is encased in the cranium, in the skull, and it has multiple layers that you have to go through. Obviously, the cranium is the skull, the scalp is above that, and then it has these layers of arachnoid matter, pial matter. So these are cells that kind of line the brain. The arachnoid covers the whole area of the brain. Pia lines the actual grooves of the brain. And these are serves as layers of protection. The blood vessels typically lie between these two, but don't have direct access to the brain in itself. They're transported through these layers or prevented from transporting through these layers into the brain parenchyma as well. And if they do, they usually have to have a mechanism by which to get in. So molecules that are too large are prevented. Molecules that have a positive electrostatic component are prevented from getting in unless they have a specific mechanism. And so the brain has this defense regulation. It's also different areas of the brain carry different functions. And while we're still trying to understand a lot of that, depending on where the cancer is, it can cause significant neurologic symptoms. And we can try and predict some of those symptoms based on where we see the abnormality. But this also prevents us from being able to completely resect it. If it's in an area that causes language dysfunction, you can't get it all out. If it's in an area that will cause significant motor dysfunction, sometimes you can't get it all out. And so the goal, while the goal is surgical resection, it's limited by this map, by this functional map of where tumor tissue is. And then, like I mentioned, the brain has this blood-brain barrier as well. So in these capillaries, in general, there's these large leakages that you can go through. There's not a, this is a normal capillary in the body, and you can see that there's these openings that molecules can transport through. In the brain, it's lined by this blood-brain barrier. So even if it goes through the capillary, it's prevented unless it has that mechanism. So things, large molecules like Taxotere, which is used in systemic chemotherapy, doesn't get into the brain. It's too large. It can't transport. There's no transporter for that. Temodar, much smaller and more commonly used in brain tumors, maybe just because it gets in. It gets in at appreciable concentrations to be effective. And then there's genetic profiling. So as I mentioned, we're trying to figure out what is the genetics of brain cancer, how does it avoid apoptosis, and what is the genetics that lead it to do that. And we know that in brain tumors, it's a complicated side. The bottom line is there's many genes. It's not a simple process. We haven't found one gene that's the main driving mechanism. The recent reports from the TCGA suggested there's 4 paradigms of genes that are involved. By paradigms, I mean big categories of gene types. And so we see this kind of heat map of multiple genes being involved. Problem is, you shut down one pathway, the tumor uses a different pathway. So can we attack multiple pathways? Becomes a potential. Or can we modify these genes with genetic therapy, viral therapy is another mechanism. And lastly, there's the immune-mediated response. So if you remember back, there's 2 forms of immunotherapy, or immunal responses, humoral immunity and cell-mediated. Humoral is the use of antibodies. So you have these antibodies and they attack the target the cells that are abnormal, identifies them as foreign or abnormal, and signals for them to be gotten rid of. And then there's cell-mediated, where you develop T cells that kind of remember and target these, and then stimulate killer T cells, and then get rid of the immune system, or get rid of the cancer cells that way, or bad cells in general. Problem is that this system isn't the same in the brain. Most of these antibodies are too large to cross into the brain, and so don't have the same humoral immunity in the brain. In the cell-mediated systems, again, the brain has microglial cells, which are a little bit different than T cells, and we think don't have that same function. The thought was, I'm assuming, the brain should be an immune sanctuary, that things that affect the body shouldn't get into the brain, and if we can prevent them from getting in the brain, we don't need the same immune system, perhaps. But when it develops cancer in the brain, then you don't have the same mechanism. But we have a different mechanism. We just don't understand what that mechanism is yet, hopefully. So what are the cancers that we're fighting with? This is all of them, so please memorize this. This is a new WHO classification, came out in 2016, and characterizes all the types of neuro-oncologic tumors. The main ones we deal with are in that top left corner of astrocytomas here, and so we're going to talk a bit about glioblastoma. Other things that we commonly see are astrocytomas, oligodendrogliomas, and ependymomas are the most common, probably. This makes up about 20% of brain tumors, though. So these are all the primary brain tumors. It means these are tumors that start in the central nervous system. About 80% of those, the tumors that we see, though, are metastatic. So they start in the breast or lung or somewhere else and then go to the brain. So if someone presents with a brain tumor, 80% of the time it's really a metastatic lesion. 20% of the time it's primary brain. But as neuro-oncologists, most of our focus is on the primary brain. The most aggressive and most common malignancy of the brain is glioblastoma. On that characterization, it's WHO grade 4. Again, grade 4 is the highest grade, grade 1 being the lowest grade. And it has a peak incidence, meaning age of presentations around 50s to 60s. It can have this MRI imaging, so we use MRI to typically make the diagnosis. It has this very irregular shape with the enhancement picking up in certain areas but not in all areas. It has areas of necrosis that you can see on the scan as well, and a lot of edema, swelling around the tumor site. The characteristic pathology is this bizarre astrocytes, so we saw that there were really irregular cells. Mitotic activity, many of the cells are dividing, which again in the brain shouldn't be the case. Vascular proliferation, so there's increased blood vessels now going to that area. And necrosis, meaning it's growing so fast that some of it is dying off. The life expectancy with treatment for glioblastoma is about 14 to 18 months. There are some factors that we know are prognostic, suggesting that patients with these tend to do better. Extent of resection, how much you can take out, clearly related to survival and prognosis. Age, how old you are at the initial presentation, and performance status. What's your functional status before surgery and after surgery? And then some genetic features that we know now. MGMT methylation, the specific gene, if it's changed so it's methylated, and less active, those patients tend to do better. IDH1 mutation might be an early precursor to tumor formation. If you have a mutation in that, it suggests you're going to do better. So we're trying to figure out 14 to 18 months still is the median, but we're trying to figure out how an individual will do. So individuals don't follow graphs and curves. Individuals are unique. And so we try to get much better than this for each individual that we're treating. That's the goal. As a group, as an institution, we're trying to move the number out farther by developing new therapies and new ways of fighting this so that most people do better. But when we're in clinic, we're only fighting for one person, right? And so as long as we help that one person do a lot better than this, it's still a success. On imaging, you can see that it doesn't take a real radiologist to see this. Even a neuro-oncologist can pick this up. You can see this large area of contrast enhancement. There's swelling. There's kind of this cystic area. This is probably necrosis, which in glioblastoma occurs because the cells grow so fast that they can't supply enough blood supply to themselves. So it's just growing at a rate that it eats up all the supply it has. The central part dies off because there's no nutrients getting to it, while the periphery continues to grow. It kills off everything in the middle during that time as well. And it causes a significant amount of swelling. So this white area around, this is the tumor, all this white is probably swelling around it. So it causes mass effect or pressure on the brain as well. And that may be responsible for a lot of the symptoms our patients have. On pathology, you can kind of see this necrosis. It's called pseudopalisading necrosis because it looks like there's a lumen to it. But what's actually happening is that central area is just dying cells because there's no blood supply left to supply them. And then you get these tufts of vascular proliferation as well. So what the tumor is trying to do is stimulate more blood supply, but it's not very smart about it. It just develops more blood vessels, but they're not necessarily connected to the circulatory system. So you get these tufts of vasculature, but it's not connected to any blood supply. So you can see vessels like this right next to necrotic areas because the tumor hasn't figured out how to connect this to the blood supply. Or, more appropriately, maybe the body has prevented it from getting to the blood supply. And then, like I mentioned, neuronal cells almost never divide. Glial cells very rarely divide. But glioblastoma, you can see multiple mitotic figures. Or, more importantly now, you can see a Ki67, which stains anything in that cell cycle. So G1, mitosis, G2, anything that's thinking about dividing, we can identify now with this Ki67 stain. So we can see how many cells are thinking about dividing. And it should be 0. But here it's about 15%. Glioblastoma can have up to 50% of the cells that are trying to divide at any time. But most of the time, these patients come in with some complaint. In all brain tumor patients, about 40 to 50% present with an initial significant headache. This is typically a headache that's persistent for several days, worsening or gradually worsening over time, and can be exacerbated by a Valsalva maneuver, bending, anything that produces increased pressure in the brain. Sometimes that's associated with nausea and vomiting, and we think a lot of this is because of that edema pattern. So you get increased edema, causes pressure on the brain, and then bending, laying down, which is why it's considered a morning headache, makes that worse as well. 20 to 40% initially present with neurologic dysfunction, weakness, numbness, something that you pick up on your neuro exam if you do it detailed enough. About 30 to 35%, though, come in with cognitive dysfunction, which is probably one of the hardest things. It's personality changes, memory problems, changes in affect, things that are a lot harder to pick up, not just for a practitioner, but also for family. The family says, well, they're just being different. And so a lot of times that's because these tumors are in the frontal lobe, which controls these functions. And because the symptoms are very subtle, these lesions can become very large before someone sees help. It's easier to pick up a headache or weakness than it is to pick up personality changes. About 10 to 20% present with a first-time seizure. So they come into the emergency room having had a seizure. Imaging reveals a brain tumor. Not all seizures have a brain tumor. Most of them are idiopathic, most of them are due to other reasons, but part of the workup for why they need to go to the emergency room for a first-time seizure is because about 10 to 20% may have a brain tumor. So that's gliomas, and now we're going to focus a little bit on treatment. So again, we're going to focus on glioblastoma, surgery, radiation, and chemotherapy. Those are our 3 lines of treatment, 3 main areas. So we want to use all of these. And how do we do that? So again, extent of resection, directly correlated to survival. So the more you take out, the better our patients do. With the caveat and the limiting factor is if you leave them with significant neurologic dysfunction, they do worse, right? So the surgeons can definitely take out everything if they didn't care about how the patient did afterwards. So we want to balance that. It's directly inversely related. More neurologic dysfunction, the worse their survival. So you have the surgeons typically try to balance that with how much they can remove without causing any deficits. The way you do that is by looking at that brain map, figuring out where the tumor is. Does it affect language areas? And we can do language mapping to figure that out. Does it affect motor areas? Sometimes you can do functional mapping to see where those motor areas, motor pathways run. Sometimes you can do awake neurosurgery as well to see if you're going to affect language. You can have them conscious enough to be able to answer some questions. After surgery, the main treatments are radiation therapy. So this is for glioblastoma, conformal fractionated radiation, small doses of radiation over about a 6-week period. And the reason that it's given that way is that normal brain doesn't divide, right? And so normal brain is fairly resistant to radiation therapy, whereas cancer cells are more likely to divide. Radiation works by developing DNA damage, right? So you're causing damage to the DNA of these cells. When they try to divide, they go through apoptosis. It gets the body to recognize that. Small doses lead to more cumulative deficits in tumor cells, less so in neuronal cells and glial cells. And then Temodar is the main therapy. It's small enough to get in, active enough to target these DNA mutations, and effective enough to improve survival. So typically patients get radiation, chemotherapy together, and then go on to cycles of chemotherapy. The cycles are same medication, but given on a monthly basis. This is kind of the standard of care for glioblastoma. It's also probably the standard of care for astrocytomas and low-grade disease as well. So this is kind of what we should be doing, what we are doing for most of our patients. They come in on a monthly basis, which is why we see them so frequently. The Temodar does cause some issues. It causes myelosuppression, so they drop their counts. It causes significant constipation, it causes nausea. The radiation causes significant fatigue. The radiation causes hair loss, scalp irritation. So someone that has neurologic dysfunctions, they're significantly fatigued, those dysfunctions get worse. The radiation does cause some swelling, so if you get more swelling, you can develop new neurologic dysfunction. Necrosis also causes swelling, so if you get breakdown of the tumor cells, they release all these molecules, and that causes some inflammation as well. So patients can fluctuate. Even when they're having a response, they can sometimes show some worsening of their condition. We want to get them through that so that we can continue to fight the cancer cells. And we watch that with MRI scans. While this is the standard of care, it's still not a curative. Our patients still have progression, still may not survive greater than 2 years. So we want to find new ways of fighting this. And so I mentioned some of those barriers. Blood-brain barrier, we're looking at ways to get through that using transporter molecules, nanotechnology to stick to a chemotherapy we think is effective, get it in. Once it's in, then it can work. We're using immunotherapy. I said this is an immune sanctuary, but can we upregulate the brain's immune system to target these cancer cells? New ways of doing the surgery to get out more tumor, causing less deficits as well. Using radiation that's implanted sometimes, using new ways of delivering chemotherapy. All these are part of the clinical trials that we're doing. So we have a whole list of clinical trials. We have a whole team dedicated to this because the goal is not just to fight the cancer. The goal is really to improve quality of life and survival for the longest amount of time. We want our patients to be happy with their lives for as long as we can. That's the goal. It's not beating cancer back. It's not putting them through so much treatment that we get to a point where we can say that the MRI looks better. The goal is really, how can we do this to improve the quality of lives of our patients? And so hopefully one of these trials, or more than one of these trials, will improve that for an individual as well as for the disease state. And so there's different phases of trials, and this is the number of trials that we opened over the past 5 years. So initially we started in 2015 with a pilot trial. We had several phase 1s the next year. Phase 1 is looking at safety of new molecules. Phase 2 is looking for efficacy. And phase 3 is a large study that's looking to compare it to what we're already doing. So we've opened several new therapeutic trials. We continue to open new trials. The goal is to find that thing that's going to work, to find ways of fighting this that are new and novel and improving our patients' lives. We've had many patients consented, about 129 so far this year, 63 enrolled in clinical trials. This is very important because this is how we're going to beat this cancer. We need clinical trials. I'll also say that even if we don't find this, we know patients enrolled in clinical trials have a much better survival than those that are not on clinical trials. Even if the clinical trial is negative, they get better supervision, their labs are better monitored, they have more doctor's appointments. So it really comes back to this team. If they see us more often, if they get involved if the team gets involved in their care, those patients do better. That's what these clinical trials tell us as well. Even the negative ones, and I have a whole talk on just enrolling in a clinical trial gets you a better survival than Temodar. So Temodar is the standard of care. It showed what our survival rates should be. But being on a negative clinical trial does even better than that. So what it really means is that you're responsible for how our patients do. We're responsible. Seeing us is the most important thing. And this is our team, so I'm going to have our team come up and then we can answer some questions. Come on up, team. We'll do. Where'd the rest of the team go? They stepped out. Some of our team is here. The other physicians.
Every single part of
we have research, admin, and providers as well. So can you introduce yourself?
So I'm Lynn, I'm a PA. I've been a PA for 5 years, all in brain.
I'm Ashley, I'm a clinical researcher. I've been doing research for about 3 years now this month. I just came here doing neuro.
My name is Selenia. I'm the senior admin for the department. I've been with Dr. Kesari's team and this team for 4 years now. And for the most part, I am one of the first admins that Dr. Kesari brought onto the team. So if you guys ever have questions, I'm pretty much your go-to person. And we do have three other admins, Nancy, Sabrina, and Florina. And there are our clinical admins.
And I'm Lucy. I'm a PA. I've been a PA for 1 year in brain tumors.
See part of our clinical team. You see us in clinic. Our research team, our admin team. Again, if we work together, we can definitely make a difference in our patients' lives. So that's the goal, right? So if there's questions, how we can do that better, let's.
I do have one question. I'm not sure if I'm pronouncing it correctly, the Garden test. If I can just get the reason for that test, patients ask, they get it so frequently, so I would have a better response when they ask about the Garden test.
Research.
Can you repeat that question when someone asks it so that
Okay.
we can hear it?
On the
So
presentation,
the question was, what is a
repeating it.
Garden test? The official name is Garden 360. It's a blood test. So just like Dr. Wagley said, surgery and pathology is very limited. And we don't want to do multiple craniotomies if we can help it. So the Garden test helps us analyze if there are markers in the blood. So in cancer, your tumor, doesn't matter where it is in your body, can shed DNA into your bloodstream. And the Garden test picks up that DNA and tells the providers, you know, are we treating it correctly? Are there markers that we can target, or are there nothing in there? And so as we treat patients, Dr. Casey has always wanted to try to get a guarded over the course of treatment so that we can see if there are any changes in their markers or if there are any new targets that come about. We know glioblastoma and brain tumors evolve over time and they can become resistant. So the purpose of the guarded test is to let us know, can we do better? Is there another treatment on the radar that we're missing? And it's very informative to us. Yeah.
So is it a test you repeat like every 6 months or every 3 months?
The goal is to do it monthly. It's not always realistic, primarily because of insurance. So that's why, you know, when we fill out the requisitions, it's really important that we say that have a C ICD-10 code, a C, you know, number, dot, whatever, indicates they have a high grade or advanced cancer, and then their insurance will cover it. It's the times where insurance doesn't cover it when we can no longer do the test. It is a $3,000 test per month.
And so the results of that will affect the treatment plan?
Correct.
It can help us get more options.
The goal, I guess the big picture, since I'm that side of things, is that we'll be able to use a blood test to diagnose and predict response to cancer, right? So we'll be able to get a blood sample, not have to do a craniotomy, and say that you have a glioblastoma with this particular molecular formation. This is the treatment you should get, and then we can watch that and see if it responds. That's the big picture goal. That's what Guardant's and blood testing's eventual goal is, that we can go from brain biopsies to liquid biopsies with a blood test and make the same clinical information available. In order to get there, we have to see what are these markers. What does the blood show now in the patients that have glioblastoma? If we get enough patients on that, then we can predict. We can say, you know, 75% of glioblastoma patients have this marker in their blood. If you could put them on Tamidar, it goes to this level. Or if you do immunotherapy, it goes to this level. And so we can predict. That's how we get to the end. Right now, probably doesn't. We're not there yet. But we have to try, right?
So you're collecting that data,
We are.
and you do that kind of research across the street?
Yeah.
Do you? You don't just send it out and someone else does the research and sends you the report?
Well, we collect the data.
Yeah.
So the data is the key. The company does the actual testing. They
Right.
give us the numbers. They don't. We work together. Yeah.
So it's a two-fer. It's a clinical use and a research use.
In your clinical trials, is there an age limit for a certain disease or?
Many do. Many have exclusion criteria or inclusion criteria. Age is sometimes one of them. Neurologic function is another one. A lot of these have molecular criteria. They have to have certain mutations in the tumor cell to meet certain trial eligibility. The therapies, the clinical trials that we have are looking at fighting specific mutations, right? So in order to select people that would potentially benefit, we want to select the right mutational pattern. Age being a prognostic factor, we want individuals that are going to be able to go through the treatment. And so typically age is part of the exclusion criteria, but not all of them have it.
It's
right?
varied, but most of them are 18 and above. There's sometimes a cap at the top, sometimes it's 65, sometimes it's 70. It just varies on which protocol it is.
Do you use ECOG then when you do that, or can you do that with a neuro patient?
So
We use ECOG, but we also use the Karnofsky performance status, which provides a little bit more granularity. ECOG is 0 to 4, whereas the KPS goes from 0 to 100. So it gives us a little bit more linearity. A lot of the neuro-oncology trials have KPS cutoffs. A lot of the systemic cancer trials have ECOG instead. They're kind of interchangeable, but the KPS just gives us a little bit more detail.
What's your understanding with the vitamin C infusions?
Can you repeat that?
What's their understanding of vitamin C infusions?
And that we do so much. But
We love them.
I know. We know. Tell us a little bit about it.
So the thought is that very high doses of vitamin C can elicit increased immune responses. So low dose vitamin C probably doesn't have the same, though it probably helps fight the common cold maybe a little bit. But very high doses that are given as an infusion can upregulate an immune response. And so we think that by upregulating an immune response, we get more activity in the brain as well. Other ways of doing that are inducing infections, right? Patients that get a brain infection at the time of surgery tend to do better. But no one wants to go through a brain infection, right? So vitamin C is probably a safer option. But it's really driving an immune response. Anything that elicits an immune response gets the system probably upregulated, more likely to recognize tumor cells or aberrant tumor cells more frequently, and then potentially stimulate an apoptotic response to that.
Put into context, at this hospital, anyone that's diagnosed with sepsis and is admitted for sepsis gets IV antibiotics with IV vitamin C. Johns Hopkins published a study that showed that if you treat septic patients with IV vitamin C along with IV antibiotics, patients tend to do better. That's only one study, but it still has some data behind it.
And
Yeah.
do they have the data here at the hospital, at St. John's, for doing this compared to
All
other
I know,
benchmarks?
when I read the article, I told Dr. Casey, he says, we're already doing it here.
It'd be
So,
interesting to
I don't know,
check
yeah.
out other.
How much
Yeah.
vitamin C are you using in that infusion?
I have no idea. I don't work in-house.
No, I was just wondering if you're using the high, you know.
I know it's grams.
It's-
It's
yeah.
not, it's not going to be.
The thought is you have to get high dose vitamin C. It's,
Sepsis, no, that
sorry, what was that?
sepsis in children, is that not related or relevant at all?
Are they, you mean, is your question, are they also treated with IV vitamin C?
Yes.
I don't know, I think the study was mostly in adults. Yeah.
So we see your patients in the clinic, and oftentimes they're very ill, have a lot of neurological deficits. What kind of emotional support does your team provide, and where do you find those resources?
That's a great question. I don't know the answer. I think emotional support is very important. We have caregiver support groups. What we do is probably not enough, right? We see them once a month, maybe twice a month. But
So
the question is, what resources do we
Yeah,
have?
we know the importance of, care for a patient doesn't stop at the chemo pill, right? We know that it has to involve the family, the caregiver, the patient themselves, of course. Among our clinical trials, I don't know if you include it also, but we have caregiver clinical trials. And so we're monitoring caregiver fatigue, monitoring caregiver stress. We're doing multiple quality of life assessments in addition to treatment-related protocols. So we know that it's important to focus on everything. Dr. Casey is also developing a supportive care clinic that has yet to come to fruition. But that'll address all of the other issues that patients are also suffering from that we can't necessarily address all in one visit. And so we hope to make that like every 3-month visit. We review your vitamins, your supplements, your seizure activity, your bone density health.
We have a new member of our team.
Stress, right? Emotional stress, the distress scale is really important to us. And then now that we have Dr. G on our team, and then of course, our great clinical social workers are awesome too. We refer to them all the time. And like Dr. Blackley said, a lot of brain tumor support groups are actually in the community. And now that we are also spread among Hoag, LCM, St. Jude, and soon to be Burbank, Hoag actually has a great brain tumor support group as well. So when we can refer, we refer as much as possible. Of course, in the immediate and upfront diagnosis, people are really scrambling to get all their ducks in order. And then once we kind of get in a good routine, we'll give them the resources they need. Yeah, but we're highly aware of that.
Do you think that we do a pretty good job of that here? We can always do better, of course.
Yeah, I think with the add-on of Dr. G and then the survivorship clinic and the social workers, of course, that resource is invaluable. There are a lot of other, in terms of how we can improve, there are other brain tumor centers that offer child life specialists for patients that have young children, psychologists, not just psychiatrists. I know we have nutrition.
Yeah.
PT, I'm sure you do a lot of PT referrals.
Yeah.
And if we could have more, like a specific, there are specific PTs in neurology, so they're kind of hard to find.
Yeah.
And speech therapy is hard to
Yeah.
find. So those kinds of more availability would be helpful.
Yeah. Sure.
But,
How
you
about
know,
financial issues? It's a big one, social work.
yeah.
We rely on our social workers to help
Yeah, they're really
and
good.
plug them into these care
Yeah.
consortiums as well. We do work with bigger organizations like the ABTA, the American Brain Tumor Association, to kind of get their leverage and the resources to our patients as well. So it's a community, and we need to get our patients plugged into that as well.
Just out of curiosity, within your career, how long have you seen the survival rate of a glioblastoma? I mean, beyond the 18
longest?
months, yeah. I'm just curious.
I have patients
You've
out
seen that-
14 plus years. Yeah. So on an individual, we
on
can't
trials?
predict.
They're
Yeah.
on trials? Yeah.
One, yeah, some of them went on trials. Many of them have some prognostic indicators that suggest that they do better. Some didn't. We still don't have a way of predicting. And so when someone's newly diagnosed with glioblastoma, I have no idea how they're going to do.
Right.
We're going to fight it one step at a time. And hopefully 10 years from now, 15 years from now, we'll have a cure and we'll give it to everyone. And so the goal is,
Nothing with melanoma here.
Yeah.
Necessarily, but
melanoma was, exactly. So melanoma, just 4 or 5 years ago, was just as dismal as glioblastoma, right? And then with new immunotherapies, it's revolutionized the way. So that's what we're hoping for. Hopefully we're doing some work now that in the next few years will revolutionize the way we fight this. And I'll give this talk again and talk about something completely different is the goal. We have a new member of our team, so just so you have another face to remember.
hello, Nancy.
What's your role, Nancy?
I'm the admin. You're all called
Yeah.
one of the
They're the brains that run this organization, right? The admins, anything, yeah, they tell us where to be, when to be, and how to do it.
Would you like to talk a little bit about patient education and how the nursing staff can help with that in the clinic? What are your expectations? What would you like to see from the nurses that see your patients in clinic? Maybe more of what we do now, or expand on that a little bit?
Well, I think, first of all, I think you guys are doing a great job. I came over from USC. The team and here is tremendous. So I think you're all doing a great job. The things that we appreciate are being able to see our patients efficiently, having kind of the information that the patient provides to you accessible as well. Kind of some of their symptoms, their vitals, their medications all make a big difference. Oftentimes they come in with a new complaint and we have to tie that to a change in their medication regimen, or we have to change their medication. So having that information that you guys provide is tremendously important. Sometimes you pick up on things that they complain about. You see them walk in, you see them sit and not maintain their posture. If you find something, we want to know about that too. Your eyes are just as important as ours, so what you see, you can relate to us as well. And then obviously we talk about some difficult things in the room, and then you see them afterwards as well and have to escort them out. And so providing that support, being there to say that maybe today wasn't the best day, but tomorrow's a new day, and kind of that approach as well. Not every day in cancer fights is a great day, and sometimes we see them in clinic on those bad days as well. So being there, the strength for them, that support is important as well.
I think, Rob and Tamara up front, they do a great job at letting us know if someone's in the lobby waiting for us that might not be as comfortable waiting in the lobby for very long. And so that's really great for us. 50% of our neuro exam is we don't even have to touch them, we just observe them. And so just kind of, as you get to know our patients coming in frequently, just like what Dr. Wagner said, if you notice something weird or off, just let us know. The medication reconciliations are really important for us. We change the decks every single day, almost like with the tapering. Steroids and anti-epileptics are really important to us in terms of what they're taking. We note that in our note every single HPI. So those things, and then vitals, you guys
We love vitals. That's how we know if our patients are doing okay. Blood pressure, heart rate. Oxygen is important because it tells us right away if someone's having a PE. Height and weight are important because it tells us what dose of chemotherapy they should be getting. And so, you know, a true height is really important, not just a self-reported height. I would say I'm probably taller than I really am. So, you know, all that stuff is really important for accuracy.
You're 6'2", right?
Yeah, exactly. So, you know, I think as you guys are really diligent and very detailed, and that's what makes the biggest difference for our patients and their care. Jen, did you have a question?
Immunotherapy I'm seeing used more and more. Is this just kind of like, is it part of the trials? I can't remember exactly.
Well, most immunotherapy is on a trial. We think that there are some molecular features that would lead us to kind of predict that there might be a response to some agents. And so sometimes we do use them off-label as well. We do that quite often because, I didn't get into it, but once a glioblastoma recurs, there's no standard of care therapy for fighting this. It's finding the right way to fight it for an individual patient. So we use all the information that we have. We ideally want them on a clinical trial because then we can find out if what we're doing is really working. But if we can't, or for any other reason, we think that they might benefit for something, we do use a lot of immunotherapy. We do use a lot of targeted therapy in addition to standard chemotherapy as well. We think that this immune mediated reaction is important, that it's probably the future of cancer therapy. It's the natural way the body fights cancer, body fights disease, right? It uses the immune system. The immune system is the most advanced system there is for fighting disease. So there's no reason we can't fight cancer using that. A lot of immunotherapy is just getting the body to recognize cancer as a foreign cell. And so if we can do that, then we don't have to fight the cancer. The body has to fight the cancer, and that's probably the better mechanism by which to do this.
In your experience with the immunotherapy, how often is commercial PPO or Medicare covering this? Or is there a cap?
On a clinical trial, the clinical trial covers it. If it's off-label, it's a battle.
Would you repeat that question?
What is, for immunotherapy, how often does the insurance cover it? Off-label, it's a struggle. Most of the immunotherapy is very expensive and doesn't have the data yet in neuro-oncology to support its use. But that's because we don't have the data to support its use, not because it doesn't work, right? So those are two different things. So if we treat patients based on what we think is going to work for them, then we argue with the insurance companies. We push back. We give them supportive documentation. We say we've done this to try and accomplish that. Until we can prove it with a clinical trial, that's what we have to do.
And that doesn't just apply to immune therapy. So all, like I would say 30% of our patients are on some kind of therapy that is not approved by insurance or not indicated per the FDA, right? So what Dr. Wiley was saying earlier was that because our treatments are limited, we have to rely on Caris testing, molecular testing, Garden testing, and if we have a target we can go after, and it might not be a brain tumor drug, it could be a breast cancer drug that we could maybe use for brain tumor, we're going to ask insurance to pay for it because it gives our patients more options. And oftentimes they don't, and oftentimes Lucy and I and the rest of the team are on the phone with insurance yelling at them or writing a letter, a very strongly worded letter. And then if that fails more than once, then we'll ask the company to pay for it. It doesn't always work out. And so some of our patients are paying $20,000 out of pocket for a pill every month. So, you know, that does occur. We're obviously trying to reduce costs to patients as much as possible, but that's where, you know, the precision medicine is so important for us, you know, to understand the tumor better, to understand the cancer better. It helps us give our patients more hope and more options.
It's a really tough kind of cancer to be involved in, isn't it, for your team? You just see a handful of your patients, all of your patients facing.
I would say that's like Nancy's 50% of her job is paperwork to get drugs for our patients.
Right.
Yeah.
Is there anything that, that you folks as support staff can tell us would help you do your job better that we can provide to you? Do you get what you need from our staff? Yeah? Do you have many patients that call your office with, say, complaints today, they're more vomiting or can't stand up and those kind of symptoms? Do they call you or do they call our clinic?
I think for the most part, we get, the admins get the call. I think that over the last 4 years, with our PAs, we've gotten better at a lot of really triaging these calls and getting them over to the appropriate, you know, if it's the doctor, if it's the PAs, and for the most part, our PAs are always available. You know, sometimes we'll send them a message and they can be in clinic and they're okay with stepping out and taking a phone call. So I think that we have gotten better at a lot, you know, like a lot of our admins. I myself can say I came in here with no experience of neuro-oncology. Yeah. I'm not an expert at it, but I've gotten better at it, and I think that we do know which symptoms are, okay, this is a 911 call.
Yeah, right.
Yeah.
I would say if you get a call from one of our patients and they can't reach us for any reason, always tell them use my chart. We're always on my chart, it's on my phone, I get it all the time. And three of us, all three PAs, have access to this pool, so there's never a time where we're not checking it. And then, you know, another thing to remember is that people have brain tumors, they have really bad memory. Yes. And so part of our job is just repeating a lot of stuff. So if you find yourself having to re-educate, reiterate, all these things, that's pretty normal. And thank you for your patience. That definitely is going to happen.
So I think we're going to end with this last bit. That every member makes a difference in survival. So the data is that the more frequently, the better, more often that you see someone, whether that be a care provider, whether that be an admin working on getting your drug approval, improves survival. So what you're doing here every day makes a difference in how long and how well our patients live. Thank you.